Hello everyone and welcome to another episode of our new oncology podcast series, Onc Now, with me, your host, Dr. Jonathan Sackier. This series was designed to spotlight the leading experts in all subspecialties of oncology, and today I'm delighted to be joined by Professor Carlos Caldas. Carlos graduated from the University of Lisbon Medical School before completing training in internal medicine at the University of Texas Southwestern in Dallas and medical oncology training at Johns Hopkins Hospital in Baltimore, Maryland. Carlos is a clinician scientist and the chair of cancer medicine at the University of Cambridge here in Britain. His research focuses on characterizing the clonal and cellular heterogeneity of breast cancer and how this may affect treatment response and, of course, survival. He's the recipient of several accolades, including the European Society of Medical Oncology Hamilton Fairley Award in 2016, the Susan G. Komen Brinker Award for Distinguished Scientist in Basic Research in 2021, and more recently the prestigious Leopold Griffel Prize in 2023. There's a lovely devotional video on their website where his friends and colleagues pay tribute to the good doctor. It's truly heartwarming. In his free time, Carlos tells me that he enjoys literature, travel, hiking, football, and gastronomy. I hope you enjoy our conversation as much as I did. So, without further ado, over to the podcast.
Pleasure to have you.
Thank you. Thank you for having me.
You're welcome. So, before we dive into your groundbreaking research, I have to ask you, what's your favorite cuisine? And when you say football, given that you've spent time in the United States of America, do you mean football or do you mean football?
And I can start with the latter. I mean football. So I'm a big supporter of a team that is still very good, but used to be top of Europe, Benfica, where Eusebio. I saw Eusebio play.
Oh.
And of course I support Portugal whenever we go to the European Championships and Cristiano Ronaldo and all of that. What is my favorite cuisine? Well, I have to say Portuguese cuisine. I like, I'm a bit of a, I like food and I like a good bottle of wine. And I enjoy European and Asian food, and pretty much anything that is well done, I'll eat. But my favorite food is Portuguese food.
Well, I have to tell you, I only recently went to Portugal and was blown away. And one of my new favorite dishes is pica-pau. It's woodpecker, because you pick it up with little cocktail sticks. And the Portuguese wine needs to be more widely known. It's a beautiful country with a wonderful culture. So maybe we'll have a conversation about these recipes. So, Carlos, in my career, I found that travel, exposure to different cultures, systems of medicine, disease prevalence, all those things enhance one's life and mind. You started in Portugal, then the USA, now the UK. What have you absorbed or been influenced by from your journey, geographic and professional? You've collaborated in your research with colleagues from around the world as one example. So you're a Renaissance man. Take us on that journey.
Well, I did medical school in Portugal, but I was fascinated by Anglo-Saxon medicine. And when I was still in medical school, I came and did a clerkship in the UK for 2 months. And I was at Nottingham City Hospital working with a great of medicine, William Jeffcoat. He was son of Professor Jeffcoat that wrote one of the, textbooks that was a landmark in obstetrics and gynecology. His son, with whom I worked, was a consultant physician at City Hospital. He was an internist and endocrinologist. So that was quite an experience. And so when I went back to finish medical school in the last year, I decided that I wanted to train postgraduate training in Anglo-Saxon medicine. But at the time, Portugal was not in the European Union, while as the UK back then had just not that far back joined. And so it was very difficult to get accreditation of medical school here. So I did the American Embassy exam, and that's why I ended up in the United States. And originally, So I applied in many programs in the US and was on the matching program and ended up being ranked very highly by lots of programs. But really, after interviewing in many places, I was just fascinated by UT Southwestern in Dallas, and that's where I ended up. The reason being that it was like what I would call a cathedral of molecular medicine. You know, it was one of the first places where you had outstanding clinical training, but also you were exposed to molecular biology, and you were expected as a resident in that program to really study it and know it and make it relevant to the patients you had seen the night before. And then, you know, I did my residency there, did the boards. So I board certified in the US in internal medicine. And then, you know, it was the choice of where to do the specialty. I wanted to do oncology. You know, many people in the training program in Dallas, you know, why don't you go into cardiology? And I remember being called by the head of cardiology and saying, you know, why are you choosing oncology? You know, you would be a great cardiologist. And I said, well, thank you very much, but I want to do oncology. So I ended up at Johns Hopkins. And again, the reason for me to choose Johns Hopkins was, again, because it was back then, and it still is, a top place for molecular oncology and genomic medicine. So it was an outstanding training program. We trained in medical oncology, and also we did all of the, you know, malignant hematology. So I did bone marrow transplant, allogeneic transplants, and so forth. But it was also the opportunity to, paid by the fellowship, to do research in top-notch labs. And so that's what I did. I was very fortunate to, you know, be in the lab of Scott Kern, who had just come out of Bert Vogelstein's operation. And so it was great because on one hand, it was a lab just starting. And so it gave me, a lot of experience of how to set up a lab, etc. But at the same time, we had lab meetings with Bert Vogelstein. So it was fantastic. So then I finished my fellowship and was offered faculty positions in a few places in the US. But, you know, I'm European. My wife is also Portuguese. By then we had 2 children, of course, born in the United States. But, you know, they were of Portuguese ancestry. They were very little. And I saw one day an advert in Nature for a position as a postdoc in Europe. There were 2 posts, one in London and one in Helsinki. And I remember my wife telling me, don't go to Helsinki, please. So I came and interviewed in London at the NIMR and at Chester Beatty Labs as part of the Institute of Cancer Research in Fulham. And that's where I ended up and did a postdoc there for 2 years. And then, you know, I ended up in Cambridge. That's a different story I can tell you later.
So you made me smile when you started off. At medical school, I thought I wanted to do obstetrics and gynecology and won the Norman Jeffcoat Cup at medical school. All about it until you mentioned I was at Liverpool. It's a fascinating journey, and it's funny how sometimes circumstances dictate where you go and take you down one particular route.
That's right.
It's a mark of the man or woman who takes advantage of the opportunity rather than the opportunity shaping their life. So I want to get into some of the specifics about your work. Your group work has basically led to the redefinition of breast cancer, and to quote from your website, a constellation of 10 genomic driver-based subtypes. Can you expand on that and talk to us about the molecular taxonomy of breast cancer into the consortium or the METABRIC initiative?
Yeah. Well, you know, I think that if you want to go somewhere, you have to have a map of how to get there. And in human disease, that's not different. So I was struck by the fact that breast cancer is such a common disease that it's got such variegated clinical phenotype. So we can see someone, usually postmenopausal, that has breast cancer and diagnosed and treated and lives with it and eventually dies with it. And contrasting that to normally or more commonly a younger woman with a very aggressive tumor that unfortunately, no matter what we do, they eventually succumb to the disease. And so it struck me that this enormous variegation in clinical phenotype, if I can put it that way, could only be explained by the intrinsic properties and wiring of the tumors. And, by looking at what little was known, we're talking back in 2008, 2009, of, if you want, the genomic anatomy of breast cancers, it was a couple of things that were quite obvious. One was that what dominated the landscapes, if you want, were not mutations, but copy number aberrations, okay? So either copy number gains or copy number losses. And the second was that there were very few mutated genes. So the genomes of the breast cancers are mostly shaped by these copy number aberrations, okay? And so then, just with some very basic knowledge of biology and of tumor biology, if copy number aberrations dominate the landscape, they are doing so by doing one of two things: either activating genes by having larger number of copies, what we call amplifications, and therefore leading to overexpression of oncogenes, or by the locus where the gene is being deleted, one copy normally, and then the second being mutated, what we call tumor suppressor genes. So that was not a big leap to hypothesize that if we looked genome-wide at copy number aberrations and then looked at the loci that had copy number gains and losses for the genes whose expression was either increased with a copy number gain or decreased with a copy number loss, by definition, we would be enriching for oncogenes and tumor suppressor genes. So that's the first thing that we did. We did copy number profiling and gene expression profiling in parallel in the same tumor. And then by correlating copy number and gene expression, we kind of narrowed on the oncogenes and tumor suppressor genes. And then the second thing we did was, again, in a way obvious, which was to say, if this is how the genomics landscapes are, if we look at these copy number aberrations that drive gene expression and try to cluster the tumors based on these aberrations, we will identify subtypes. And then using some simple maths in the power calculation, we wanted to identify subtypes that would be at least 5% or so of the breast cancers. And so that required a certain number of tumors to be studied. And that's why we ended up with 2,000 tumors. And then, using a purely data-driven approach, because we don't know what the ground truth is, how many subtypes there are. We identified these 10 subtypes. It turns out that later one of the subtypes we divide based on estrogen receptor status, so we now talk about 11. And so these are genomic entities. And then when we look at the patients where we have profiled the tumors and classified the tumors into originally one of these 10 and more recently one of these 11 subtypes, we see two things. They have very dramatically different clinical outcomes, number one. And number two, they have very dramatic differences in response to therapy. And so this classification is not just prognostic, it is also predictive. And I think it is a landmark. I'm very fortunate to have done this with my colleague Sama Parisu, that used to be in Cambridge, is now in Vancouver. The original paper was published in Nature in 2012, and I was amazed the other day to look, and it's been cited more than 4,000 times. So,
yeah. Well, of course, it's a field change. It's a paradigm shift in the way we understand it. I mean, I remember back during my training, and, it seemed to be one homogenous disease, but clearly wasn't in terms of its clinical, its clinical behaviors. You would see a young woman who, as you say, didn't matter what you did, the outcome was dreadful. So can you expand a little bit with that background as to how this taxonomy will lead to better clinical comprehension and programs to monitor, treat, and perform even more relevant therapeutic studies, because calling it stage 2 breast cancer is an irrelevant.
Yes.
You're not comparing apples and apples. It's apples and stones.
That's correct. So the first thing is that at baseline, when you're diagnosed with breast cancer, if you were to stratify into one of these subtypes, that contains enormous prognostic implications. So there are subtypes which are really very indolent breast cancers that have, extended long-term survivals. Okay, whereas there are other subtypes that are extremely aggressively clinically. So there is prognostic information. There is information, as you hinted, as to how monitoring should be organized for women, because in a subsequent paper that we published in 2019, we showed that amongst ER-positive disease, and let's focus on that, which is about 75% of breast cancers are ER-positive, depending on your genomic subtype, there are subtypes where really most of the relapses occur in the first 5 to 10 years, where there are other subtypes where women continue to relapse 15, 20, 25 years later. So that evidently has a major clinical implication, which is that you can tell a woman with one of the subtypes where most of the relapses occur in the first 5 to 10 years, that after that period of time, they can kind of be reassured that it's highly unlikely they're going to be relapsing, whereas in other women, you have to continue to monitor them effectively for life. Okay?
Okay.
Now, let's look at a different subtype, which is the triple-negative breast cancer. So these are breast cancers that are negative for estrogen receptor, negative for progesterone receptor, and negative for HER2. These tumors are traditionally very aggressive, but are the ones that are better responders to chemotherapy. And if a woman is diagnosed and is alive 5 years later, there is a very high chance that she's cured. Okay, now, we identified 2 genomic subtypes of this triple-negative breast cancer. And what is very interesting, or interesting is maybe not the word, is an important clinical observation, is that whereas if you are in the main subtype of the triple-negatives genomically, which we call integrative cluster 10, if indeed you are disease-free at 5 years, you are almost guaranteed to be cured. Less than 10% will relapse from year 5 onwards. If you are of the other subtype of triple-negative breast cancer, which is in integrative cluster 4, unfortunately, when you reach 5 years, you still risk relapsing up to 10, 15 years later. So again, important in terms of monitoring. And then finally, in terms of therapeutics, the problem is that there you really, I used to, an image that I use, it's to say it's not about the hammer, it's about the nail. And, the way oncology advances, the way clinical trials are done, which are mostly sponsored by big pharma, the fact is that they don't want to slice and dice. They want blockbusters. And clinical trials are not designed with stratification in place for the most part. They separate, of course, ER positive and negative and HER2 positive and negative, but our molecular stratification has not yet made it into clinical trials. And that is really a tragedy, because it's 12 years ago that we published a paper. And I think that a lot of the things that we see, for example, only a minority of patients, a small minority of patients with triple-negative breast cancer benefit from immune checkpoint inhibitors. And, it wouldn't it be very nice to stratify the triple-negative breast cancers and identify those that are going to benefit from immune checkpoint inhibitors. Same thing is true in ER-positive disease in CDK4/6 inhibitors, which are the patients that don't get any added benefit from receiving these very expensive drugs and could just be on hormone therapy. So I think that, we're still in a stage of the practice of oncology where trials are mostly driven by the therapy instead of driven by the biology of the disease.
Yeah, that's a great point. And as medicine faces many challenges, not least of which is the cost of medicine.
Of course.
Giving expensive drugs to people who aren't going to benefit.
Yes.
Going to not only not make sense because of, any drug that works also has side effects. And if you get the side effect benefit, that's not a good thing.
Yeah.
So earlier this year, published a paper, The Power and Promise of Patient-Derived Xenografts of Human Breast Cancer. Can you talk to us both about the power and the promise, please?
Well, so we have a very significant problem with the fact that we identified and defined that breast cancer is 11 genomic entities. Because now, any therapy that you do, any look that you do of combining therapies, etc., needs to take this into account. And that leads to a gigantic, what I call a combinatorial problem, and the feasibility problem. How would you do the clinical trials that would take this into account? And how would you test new therapies and new combination therapies? This is theoretically an insurmountable problem. You don't have enough women and time to do all the clinical trials that you would need to do this. So are there, and there has been a seeking for models for a long time, are there models that mimic disease in enough degree of phenocopying the disease and with enough granularity that what you learn from the models can help you in the clinic? And of course, a lot of drug development has been done with cancer cell lines. And we know that although the cancer cell lines can be very useful, they also are very often very misleading and very poorly predictive of response in real patients. We also know that we can make mouse models, genetically engineered mouse models, transgenic mice and knockout mice, where we, one gene at a time, at most 2 or 3 genes. It's very difficult to do more than 2 or 3 genes in one mouse because of breeding and all of that, where you can try to mimic the human cancer. But again, a breast cancer doesn't have just one mutation or 2 or 3. It's got a constellation of mutations and copy number aberrations. Every tumor probably, somewhere between 15 and 50, okay? So there's no way the animal models can reproduce this. So one way is to try to grow human tumors directly in the mouse, what's called a xenograft. Okay. The problem with doing that, or just 2 problems. One is that you need to have highly immunosuppressed mice. And so that is a problem for testing, for example, immunotherapies, immune checkpoint inhibitors. But we can fix that, actually. We'll get that in a second. The second is that not all tumors will take in the mouse, only the more aggressive ones. Although as mice and as we get better, increasingly we can also create models from ER-positive disease. And what we and others have shown, but my group in particular in breast cancer, and there are only 2 or 3 groups that have done similar work, but really the more substantive work has been done by my group, is that human breast cancer xenografts growing in the mouse are remarkable copies of the tumors in the donor patient. And they are remarkable copies, particularly of the genomic heterogeneity in tumors, because tumors eventually all become resistant to therapy because they have the ability to evolve. They're little Darwinian systems. And, what is remarkable is that when you put the tumors in mice, grossly speaking, they keep this heterogeneity, okay? And then the second observation that we and others have made that is truly remarkable, because just think about this for a moment. Once the xenograft starts growing in the mouse, the only human cells that survive are the malignant cells, okay? So now that tumor in the mouse, all the fibroblasts, all the stromal cells, the blood vessels, etc., are all of mouse origin, okay? And when you look, the tumors are phenocopies of the donor tumors, morphologically, okay? In a lot of these tumors growing in the mouse, if you do a section and do an H&E section, and you then do the same from the donor tumor in the human patient, and you scramble the slides and you show it to a breast pathologist, they are not able to tell which one is the human tumor and which one is in the mouse, okay? So this is an absolutely remarkable thing, because I just told you that except for the human cells, all of the other cells, the malignant cells, all of the cells in these xenografts are of mouse origin. So there is a remarkable element of instruction in the malignant cells, that they are able to dialogue with the mouse cells and tell them to organize themselves morphologically. This is just remarkable. And so this makes mouse models even more relevant, xenograft mouse models. And you can test drugs in them, and you can do clinical trials in the mouse. And so I'm not saying that they will replace clinical trials, but I'm saying that they are a very good surrogate.
Yeah.
Now, in a very small number of patients, you might think of using this as avatars. So if you have a mouse from a given donor human patient and then subsequently relapse, you could, in theory, have tested therapies in these now avatars from the tumor of the donor patient and try to match the treatment to that individual patient. I think that that is certainly possible and has been done, but it's the exception, not the rule. It's logistically very difficult. But if the xenografts mimic the overall properties of the tumors and the genomic subtypes that I told you about, the 11 genomic subtypes, and there are models now for all the 11 genomic subtypes, you can just see that you can try to use them to test preclinically dozens of therapies. And you don't even need to do it by using a large number of mice, because what we have shown in a paper that we published in 2016 is that you can do short-term cultures from the xenografts in the Petri dish. And from one xenograft, you can populate, tens of wells, hundreds of wells. And so you can test many different drugs, from dozens to theoretically hundreds in these, cells that were derived from the xenograft, that were derived from donor patients and look very much like the donor patient tumor, and use this. And so that's the promise of the xenografts.
No, it's absolutely fascinating. I think I could take this in a direction that we'd have to do an entire podcast on how animal models could change, and in silico approaches could change the way that we think about clinical trials. Because, I guess the other thing is speed to the clinic. We've got to do things to accelerate, because
that's absolutely right.
Therapies, when you've got a patient in front of you who you think might be helped by something you're doing in a clinical trial, in your specialty, that must be heart-wrenching. So, but I do need to move on to other subjects. I think also suggests we're going to have you back on to dig into more detail about some of these things. So you've also done work looking at the circulating plasma cell-free tumor DNA as a marker of tumor burden, better than circulating cells. Can you tell us about what this means and the implications for diagnosis, monitoring, treatment, and prognosis, of course?
Yes. So as tumors are growing in the patient, as in any tissue, in normal tissue is the same thing. There is always constant tissue regeneration, and our cells dying. If you treat a tumor, and if the treatment is working, more cells are dying. Okay? If a tumor is small, the number of cells it has is a given number, and the number of cells that die is a given number. If the tumor is 10 times bigger, you would expect 10 times more cells to die, and therefore 10 times more of debris from cells to eventually get into circulation. So that's exactly what happens. Cancer cells grow, but some cancer cells die. As they die, they release the nucleic acids that are in the nucleus, DNA. That DNA is fragmented, because when cells die, the DNA fragments. And then that material gets into circulation. It turns out that it gets into circulation not as completely free DNA, it's DNA wrapped around nucleosomes, okay? And so it's got a certain size. And there are in the plasma, lots of things that make it hard for anything to survive in circulation except what should survive, blood cells, etc. And so these nucleosomes are constantly suffering, both mechanical and also, protein digestion, etc. And so it turns out that DNA is trimmed to what wraps around the nucleosome, hence the length of the cell-free DNA. So now you have cell-free DNA in circulation. By the way, it's not just cancer cells that do it. If you go and run half a marathon, and you then take blood from an individual that has run a marathon, there will be cell-free DNA because there will be muscle cells and other cells that die and that releases it. Now, the DNA coming from the tumor cells has a barcode. Why do I call it a barcode? Because it has the mutations that have accumulated in the cancer cell. So now you can distinguish the cell-free DNA coming from a tumor cell because it's got this barcode versus the one coming from normal cells. Okay. The other thing is the relative abundance. Whereas from a normal cell, when the normal cell dies, it releases DNA into circulation, it will be randomly distributed along the genome with the same distribution. If it comes from a tumor cell that has very massive copy number gains or copy number losses, the part where there are copy number gains or losses will have either more or less DNA. So you can quantify chromosomes, believe it or not, in cell-free DNA. So what we did was some pioneering studies that really, for breast cancer, were really pioneering, showing that the amount of cell-free DNA reflects tumor burden, so it can be used to monitor how much tumor there is and how the tumor is responding or not to therapy. It can also be used to identify the mutations and actually to do a liquid biopsy in patients with metastatic disease that have, metastases in the lungs, in the bone, in the liver. You can't possibly or ethically or logistically go and biopsy all of these tumor sites. But if they are all releasing cell-free DNA into circulation, you can do a liquid biopsy. You get a blood sample and you're really sampling DNA coming from all of these different locations. And so cell-free DNA can be used to monitor tumor burden. It can be used to identify mutations. It can be used to identify emerging mutations that arise from resistant sites, etc. So I think there is plenty of evidence for their use this way. Using circulating cell-free DNA to diagnose, so in screening, I'm significantly more skeptical. And let's just leave it at that. I'm very skeptical. I think that, you're going to create a gigantic problem of, if you do this in a population basis, of identifying things, false positives, even if the number is very low, you would be having to do tens of thousands of tests, MRIs and PET scans and so forth. So I'm very skeptical of using it there, except maybe for some very high-risk populations, maybe BRCA1, BRCA2 carriers that have a high lifetime risk of developing breast cancer, maybe in limited cases like that, but on a population basis for screening, I'm extremely skeptical.
Right. So, changing topic again, and thank you for that, but patient-derived tumor cells can be rapidly used for various studies, importantly, high throughput in vitro drug screening. I remember when I was newly qualified, back when there were gas-powered street lamps, that this was on the horizon.
Yes.
In Liverpool, but never quite bore fruit. What's the state of the art now?
Well, so the technology has gotten better, and you can identify rarer and rarer populations of circulating cells. I think that the problem is, the amount of these cells is so minute that it's very difficult and technically finicky to get them. Only very specialized places, let alone then growing them up in the laboratory in sufficient amounts that you could do what you're alluding to, drug testing, etc. So this is possible in highly specialized tertiary centers that do it very well. I'm thinking of, for example, Manchester and Caroline Dive's work in lung cancer. But for routine use, for tumor monitoring, for liquid biopsy, I think circulating tumor DNA has surpassed circulating tumor cells. And, there is no going back because it's way more sensitive. It's easier to do. It's technically more feasible. It's significantly cheaper. So I think that and it's more dynamic, more sensitive. We showed in the paper that you alluded to back in 2013, we directly compared in the same patients circulating tumor DNA with circulating tumor cells in the same blood sample, and circulating tumor DNA was better for all the reasons that I mentioned.
Right. So something else that popped up in reading about you and your work. Vitamin B5, pantothenic acid, pantos, the Greek word everywhere, a ubiquitous vitamin or vitamin. Last year, you published a paper on the possible role of B5 in oncogenic metabolism and tumor progression. What conclusions can be drawn from this work, and are we any closer to identifying other environmental elements in cancer etiology?
Well, thank you for mentioning that work. I hesitate on talking about it because I don't want to take credit for, as you noticed, we were participants in the study, but we were not leading the study. So I want to be very careful, very proud to have been part of it. I think it's a very important piece of work. It raises the fascinating possibility that a subset of human tumors driven by a particular oncogene called MYC, and by the way, there are about somewhere between 5 and 10% of ER-positive breast cancers that are driven by MYC, that in those there is a dependency on the metabolism driven by this vitamin, and that therefore this would open the fascinating possibility of therapeutics using vitamins. But I really would not want to say much more because I don't want to take credit for work that I have not led. But again, I repeat, I'm very proud that our xenografts could have been used to test and do some experiments that contributed to this amazing paper. And moreover, as I said, also, I'm very intrigued by the possibility of a subset of ER-positive tumors that are driven by amplification of MYC, where this could be a therapeutic possibility. And I would leave it at that there now, because it's not work that I'm going to take forward. The people that led the work, I'm sure, are pursuing it.
Right. And other environmental factors? Anything else? No.
Well, so yes, it's very clear that, obesity is prognostic and predictive in breast cancer. It's very clear that, hormone exposure, when do you have your menarche, how many children do you have, do you breastfeed, all of that are contributing risk factors and modulate the clinical behavior of breast cancer and the possibility of having breast cancer in the first place. Cigarette smoking, doesn't appear to be a major factor as a risk factor in breast cancer, but I'm sure it also contributes a bit. Are there things in the environment and in our, way of living? I'm sure there are, because a Western woman eating a Western diet has about a 1 in 7 to 1 in 8 lifetime risk of breast cancer. That is not the same thing in the less developed world. The incidence seems to be lower than that. So there's clearly environmental factors. There might be ethnic factors too. There is a suggestion and probably very good epidemiological data that in Africa and women with African ancestry, that there is a more likelihood of developing more aggressive forms of breast cancer, in particular triple negative, and what's called inflammatory breast cancer. So you have to adjust your practice to local factors that might lead to you having to adjust it. So yes.
Okay. Watch this space. So what current developments in breast cancer causation, diagnosis or treatment are within reach or just over the horizon that have you most excited? And I guess going back to my prior question, observations, I am fascinated by the phenomenon of pseudoscience on the internet and, the nonsense that gets promulgated. I saw one the other day that drinking a glass of water at night just before you go to bed at night reduces your chance of heart attack, stroke, and hypertension. And I'm thinking the only bloody thing it's going to do is you're going to get up in the middle of the night for a pee and stuff your toe on the edge of the bed or slip up. And, it's just, that's why I was pushing, because, patients are out there and they're frightened. And especially if they get a diagnosis, they have to deal with this anxiety that might be, driven by nonsense they read on the internet. So that was why I was pushing. So anyway, what is at the horizon or just over for etiology, diagnosis, or treatment that has you excited?
Well, I think, one of the most important realizations and discoveries, if you want, made in, the last 15 years, 20 years, and most of the work has been done actually in the last 10 years, is that we increasingly realize that tumors are cellular ecosystems, not just the malignant cells, but also the cells from the host, and not just immune cells from the host. And so this understanding of tumors as ecosystems of cells has to profoundly impact the way in which we do cancer medicine. It's going to have impact in diagnosing, in prognosticating, and eventually tailoring therapy. And so I think that this will be facilitated by technology, the ability to analyze tumors at single cell level, digital and computational pathology, bringing machine learning to the practice of oncology at different levels. So, for example, it is already reality. Automated or semi-automated, semi-supervised reading of mammograms. Okay, so this is not replacing the radiologist, but it's using machine learning and artificial intelligence to look at thousands of mammograms and then highlighting the ones that the computer is not certain and asks the radiologist, highlights the one the radiologist needs to look at. This will have profound implications in manpower, for example, in the NHS. Another area is digital pathology. So increasingly, pathology departments up and down the NHS, eventually all of them, will digitize all the slides. So now you have a digital copy of the slide. Okay? So that has several implications. It means the pathologist no longer needs to be in the hospital to read the slides. Okay? So work-life balance, post-pandemic, how we all adjusted, difficult retaining personnel, etc. You'll sit in front of your computer at home and read the slides because it's as good as being looking under the microscope. Now, once you have the slides digitized, they exist as pixels in a computer. So now you can start applying machine learning and artificial intelligence to look at the slides and quantify things in the slides, do tumor grading, do scoring of estrogen receptor immunostaining, etc. So all of that is not science fiction, is reality, is coming. And it will make, again, things way easier, more streamlined, requiring less personnel, being more objective, etc. So that's another. And then finally, as we showed in work that we published in 2022, which was again pioneering, using machine learning to integrating all of this data that you can acquire a tumor, from pathology to gene sequencing to gene expression, etc., and bring it all together and using machine learning to come up with better predictors of whether you're going to respond to treatment or not and what is the more indicated treatment for your tumor. I think this is the future, is going to be taking tumors and considering tumors as cellular ecosystems and using machine learning, artificial intelligence to help the human in doing better diagnosis and better selection of therapy. And of course, we'll continue to have therapeutic developments, watch the space of ADCs, cellular-based therapies, etc. So all of this will continue, and pharma and biotech will continue to invent new drugs and new treatments.
Fascinating. When you realize just how much is going on, it's really an exciting time to be in your
specialty. No question.
So much going on. Finally, Carlos, a question I like to ask all guests: if a magic genie granted you 3 wishes for your area of healthcare, what might those wishes be?
Well, I think, we have to think globally in the world, and I think access to healthcare in, the less developed world is one area of priority and public health. I think the second would be, what I alluded to, that we bring in new technologies and new ways of analyzing tumors that will increase the precision of diagnosis. And then the third area is going to be access to new therapies, and that this access to new therapies is driven by need and not by profit.
Yeah. Well, And I think some of your observations of things that are happening, like the use of supervised AI, human-enhanced AI, artificial and real intelligence, will hopefully help us do some of these things by redeploying resources. Sadly, I'm afraid that's all we've got time for today. I'd like to thank Professor Carlos Caldas for being with us today on another episode of Onc Now, and frankly, for everything you and your group are doing for folk who are living with breast cancer. A real pleasure to chat with you, and I hope we shall have the chance to do it again.
Thank you. Thank you.
So, folks, thanks for listening to this episode of Onc Now. If you've enjoyed listening, and I suppose if you're watching this you must have, please subscribe on Spotify or Apple Podcasts or wherever you get your podcasts so that you never miss an episode, and check out the archives. There's going to be lots of great episodes there. Until next time, I'm Jonathan Sackier. I thank you for listening. Please, everyone, stay safe, stay well, stay curious. Bye for now.